I'm Evan Muse. I'm a cardiologist and clinical researcher at the Scripps Research Translational Institute, and I'd like to highlight some of the ongoing and future projects that we have in the cardiovascular disease space, mainly as it pertains to genomics and digital medicine. I'd like to start it out by bringing it home by presenting a case. Let's start with this 55-year-old female that presented with chest pain to a rural clinic. She lives in the mountains, so it's not always well-resourced. She noticed her first episode of chest pain about 2 weeks prior. Maybe lasted for 20 minutes, had some shortness of breath in addition to lightheadedness, but then it went away. The second episode occurred 3 to 4 days later, and again was pretty much similar to the first episode that she had. However, it wasn't until that she was woken up the night prior to coming into the clinic from sleep with this chest pressure and a squeezing sensation that also left her lightheaded, causing her great concern. Of course, I should note that she has well-controlled blood pressure, but she also has a family history of premature heart disease, with folks having coronary artery disease and heart attack at an early age in her family. So I always like to think, what are the next steps here? What do we need to help serve her and to diagnose what's going on in her condition? But also, are there things that we could have done differently if we had more information? So even in COVID times, cardiovascular disease remains a priority. It's still the #1 cause of death, both in developing and developed nations, with coronary artery disease, heart attack, and stroke ranking near the top. Luckily, we have some guidance about how to reduce our overall risk, and the American Heart Association has laid out what they call Life's Simple 7. It reminds us to consume healthy diets, have regular physical activity, maintain our weights, not smoke, control our blood pressure as well as our lipids, and to be cognizant of our blood sugar levels, especially if they're diabetic. While our institute is carrying on several research projects aimed at looking at many of these Simple 7, I'd like to introduce a few that will amp things up a bit as well. Luckily, in the age of innovation, many digital devices have now come from the consumer market and also into our clinical space. Innovations like the handheld ultrasound or the smartphone-enabled electrocardiogram have really changed what we do in practice and are continuing to change week by week and month by month. But it's not only these devices in cardiology, but it's basically from head to toe, nearly every medical subspecialty. And I know you've heard discussions about what's going on with the cardiometabolic space in the PROGRESS study, as well as using digital sensors to track COVID disease as well in the DETECT study, which is exciting. I'm going to concentrate on some of the items in the middle of our screen, that handheld echocardiogram, as well as electrocardiogram as well. When we think of many of these sensors, they're now pretty much ubiquitous in our daily life. They're embedded in our clothes and wearables and also automobiles, et cetera. It's such that we can now gain so much more insights into our own body's signals rather than just a one-off blood pressure measurement or getting our weight at the doctor's office maybe once or every few years. It's not just vital signs that we're looking at, but it's also blood signals as well, whether that be blood sugar levels or even lactic acid or even other metabolites that tell us what our physical fitness levels are, or even if we're getting infections, right? So we have a whole host of sensors, not only ranging from vital signs, but also into the chemical and biologic aspects of what's going on inside of us. And these have transitioned to allow us to understand so much more about our bodies, not only to diagnose diseases, but also to prevent diseases as well. Let's think about the electrocardiogram, better known as the ECG. The electrocardiogram gives us a readout of the heart's electrical signals that allows it to beat, whether it's 60 beats a minute, 80 beats a minute, or if you're running a triathlon, maybe 130 to 140 beats per minute. What we have now is so much different from the early electrocardiograms when a patient had to submerge their arms or legs into pools of water. Let's hope that our woman presenting to the clinic with chest pain didn't have to undergo a study such as this. Luckily, Now we have devices which are a whole host of wires that allow us to get different electrical vectors of the chest to understand what's going on, not only with the heart rhythm, but also understand whether there's any conduction system abnormalities or even damage to the heart muscle. Increasingly, we've seen novel ECGs take off, and now I'm sure many of you in the forum have a smartwatch or even a smartphone that is enabled with either a single lead electrocardiogram like the smartwatch on your right, or what we see on the left, which enables us to get 6 different leads as part of the 12 lead electrocardiogram. Work has been done very rapidly over the past few years to look at the hidden signals inside of the electrocardiogram. Typically, we're looking at heart rate, heart rhythm, and large effects that we see as part of the ST segments or T waves and features as part of those electrocardiograms. But more and more, we've started to understand that there are signals hidden within the electrocardiograms that can not only give us better idea about the current health status, but also prognosticate or even predict the occurrence of disease down the line. This has been done with arrhythmias such as atrial fibrillation or long QT syndrome, and even with dysfunction of the heart muscle that leads to left ventricular dysfunction and ultimately heart failure. Our group has taken an approach that's a little bit different from others. In collaboration with my colleagues Amitabh Pandey and Giorgio Quer, we now have over 2 million electrocardiograms from a whole host of patients with a range of diseases. We're trying to ask the question of what input signals are truly needed for a diagnostic electrocardiogram that does away with the traditional wires that are seen with the gold standard devices now. It's not uncommon for when a patient needs to get an electrocardiogram that those wires are put in the wrong place or non-standardized positions, or unfortunately that a certain clinic might not have an electrocardiogram at all because of the cost associated with it. So we're now embarking on a host of research to allow us to ask the question of maybe using a smartphone enabled or even a smartwatch enabled electrocardiogram. Can we get all the features from the traditional electrocardiogram that give us insights into heart attack, arrhythmias, and conduction system disease, which is very exciting. Moving from the electrocardiogram to the echocardiogram. The ultrasound has been one of the major players in diagnosis. Many folks coming into the emergency room with chest discomfort or even abdominal pain, the docs oftentimes query whether there's a kidney stone or a gallstone, etc. Dr. Topol published what is one of the first medical selfies of this century, if you will, being able to use a handheld ultrasound to get images from various body parts in the privacy of one's home. And these devices have now allowed us to take these devices not only from specialty clinics, but also potentially to rural and mountain clinics like our patient at the beginning of this case. Unfortunately, not only performing echocardiogram, but interpreting that echocardiogram can be difficult. You saw on the slide previously, many of that can look like a snowstorm in the untrained hands. And I know my echocardiograms at the very beginning of my training looked like something very similar. However, now deep learning algorithms have come to help us understand what's actually going on in these images. Not only tell us if there's pacemaker leads, whether there's chamber dilatations, or whether there's hypertrophy of that muscle, but also to tell us whether we're in the right position to even gather the right sort of data. And similar to electrocardiograms, there is oftentimes hidden data within these echocardiograms that can help us prognosticate about the future, even in the setting of a normal heart function. We're hoping that one day these sort of algorithms can be used to allow physicians to practice at the top of their license. So if they're alone in a clinic and need some assistance, then the algorithms can help guide that practitioner into understanding where the biggest issues are for that particular patient. We're currently working with the Philips Lumify group on understanding what a teleultrasound system can do as a first phase of a multi-phase project. Here, I like to call it the Echo Mentor. Say that you were an on-call cardiologist in the middle of the night and were asked to go perform a difficult echocardiogram in the ICU. It would be nice to be able to phone a friend, and most devices these days don't really allow us to do so. But using certain technologies that are now made available, we can utilize the Echo Mentor program to dial in to a professional sonographer or attending level cardiologist to get some better assistance, not only helping us move that probe in a certain direction, but then to interpret the findings and make key clinical decisions on the spot. Typically in a hospital, an echocardiogram is ordered, performed many hours later, and then read hours after that. It takes almost half a day or even more for that physician on the ground to be able to utilize that information to guide patient care. We're now looking at how, after a brief training episode with novice ultrasound users, such as medical residents, nurses, and even early cardiology fellows, how, after learning the ins and outs of the machine itself, if utilizing the Echo Mentor helps them gain proficiency and skill doing a bedside echocardiogram much more quickly than they would if they were out on their own. In addition, we're hoping that being able to have a live feed with a attending level cardiologist will help one actually make sense of those images. Of course, we have two phases of this project, and we're able to ask many questions within this, not only if those that use the Echo Mentor first are more proficient than those that use it second, or vice versa. So I'm really excited that this project will be hitting the clinic in the coming weeks. However, there are companies that have worked on nice algorithms as well that can give you instantaneous automated guidance as to whether your probe is in the right position. You can see here on this screen, it's telling you to tilt the probe down, but slowly, in order to get a better picture of this apical view, which is occurring on your screen here. Now, with our collaboration, we're not only looking at programs such as the Echo Mentor, but also looking at how instantaneous global longitudinal strain, B lines in the lungs, and cardiac output assessment can help us assist patients in their journey much quicker and earlier than we would have previously, especially those presenting with heart dysfunction, potentially having shortness of breath or chest pain, like our patient at the beginning of this presentation. I'd like to pivot a little bit into looking at the genomic side of things, right? Genomics has an opportunity to guide us into prevention, but also treatment for our patients, whether they need to be on statins, PCSK9 inhibitors, these are medications that lower one's cholesterol, or whether there are other interventions that could be more useful in them to prevent disease in the first place. We have now come to realize through genome-wide association studies of common diseases that there are complex alleles that make up genomic risk scores or polygenic risk scores that can tell us whether individuals that are a high genetic risk or low genetic risk for certain diseases. We have done a lot of work in the atrial fibrillation space, where we carried out one of the first prospective studies of a polygenic risk score in a patient population presenting with arrhythmias. But also there are nice polygenic risk scores for cardiometabolic disease and different cancers as well. We've turned our focus recently towards coronary artery disease, and in collaboration with Ali Torkamani and Nathan Weininger, are trying to understand how polygenic risk can guide one's preventative strategies moving forward. We know that folks at the highest polygenic risk of coronary disease on a population scale are more likely to be diagnosed with a cardiovascular disease event or have disease in their lifetime. But what we also know is that even the folks that in the highest polygenic risk, as you can see on the right-hand side of your screen, if they follow Life Simple 7 and actually have healthy lifestyle and are on the appropriate medications, they can dramatically lower their risk of developing disease in the long run. In terms of the coronary artery disease space, as I mentioned, Dr. Torquemani has been putting forth a PEPPER study to look at how to guide statin optimization in a primary prevention cohort. And I'm excited to be a part of this study with him and utilize our clinical patients moving forward. In addition to making a genomic-driven biorepository, where hopefully we can start combining much more of the genomic insights that we can get with our very complex electronic health records and cardiovascular studies that we have in the cath lab and otherwise. In the atrial fibrillation space, we're embarking on some work with one of our cardiology fellows, David Yu, and one of my colleagues, Dr. Matthew Price, in trying to understand the role of a polygenic risk score for atrial fibrillation in patients with a with a patent form in ovale. This is a connection between the left and the right side of the heart that can increase one's risk of stroke in the right setting. Also, collaboration with my colleagues at the Sanford Burnham Previs Medical Institute, Drs. Larson and Colas, where we hope to be able to use genomic-driven insights to improve drug development in the atrial fibrillation space. So overall, hopefully you've come away with several insights to where we here are trying to better align and understand the human condition in the cardiovascular space on multiple levels, not only from what's going on in medical imaging or in the environment, but also what we can get from the genome, the microbiome, the electronic health record, and also consumer-driven medical sensors. And we do this because this flight that we're on is very complex, the human condition. And we hope that the next time we're coming in for a landing, which is one of the most complex phases of flight, that we can do so with all the information that we have available to us to make this flight the most safest and best journey that we can possible. I want to thank all my colleagues at the Scripps Research Translational Institute and the Scripps Clinic for being great partners and allowing us to do such great work in the cardiovascular disease space. Thanks again.